Absolutely. And one of the key things before you intubate, before you do anything else, is patient positioning. So Larry, why don't you go over patient positioning for us for intubation?
Sure, I'd be happy to. So patient positioning is actually one of the most basic but most essential skills that you'll learn, because you can often increase your chances of successful airway management in intubation by doing simple maneuvers to optimize the airway anatomy through positioning. The first thing is to adjust your table height. You want to make sure that the table is the appropriate height for the ergonomics of managing the airway. And what that means is that it has to be different for each person, because we're all different heights and different builds. The patient's head should be approximately at the level of your waist. So this actually patient's head is a little bit low. I'm going to raise the table height here. And this is going to really improve the ergonomics for mask ventilation, for direct laryngoscopy, for intubation. Now the other thing that is extremely important is actually positioning the patient's head and airway anatomy to maximize your chances of obtaining a good view of the glottic opening. And to do that, we try to place the patient in something called the sniffing position. Kyle, do you want to demonstrate the sniffing position?
Yeah. So the sniffing position is almost like you're sniffing a flower. You flex and extend to help open up your view. So you flex and extend to open up your airway.
That's a great demonstration, Kyle. Now there's one more positioning tip that I want to share with you, and it has to do with positioning patients who are obese. There are other tools that we can use to establish the optimal position for these patients. But basically we want the external auditory meatus to be at the same level as the sternal notch. And you can see on this mannequin that's not the case. We do have special tools we can use, like a troop elevation pillow. You can also use towels and other padding to put behind the shoulders and behind the head to achieve that position. And by optimally positioning that obese patient, you'll find that it'll be much easier to instrument and manipulate the airway. Great, so now that we know how to effectively establish mask ventilation for a patient, I'm ready to show you how to perform direct laryngoscopy and intubation. But before we get started, the first thing we want to do is to protect the eyes, because we never know when we might accidentally brush against the eyes and create a corneal abrasion while we're manipulating the airway. So a little eye tape is handy right about now, pre-torn and ready to go, so that you can go ahead and tape the eyes closed and protect them. The next step we want to do is we actually now want to remove the mask, because we're going to go and attempt to instrument the airway. And we're going to remove anything in the airway, such as this oral airway that we had placed earlier. Now the next step is to get some of your airway equipment ready. We want to have our endotracheal tube, which is styletted. It has attached to it a syringe with 3 to 5 cc's of air that we'll use later. We also want to have a laryngoscope. In this case, this is a Mac 3 blade. It's curved and it has a light at the end. When we're ready to go ahead and attempt laryngoscopy, we first want to go ahead and open the mouth as wide as possible. You may notice some attendings and some advanced residents doing this nifty little thing where they just tilt the patient's head back and they don't touch the mouth, and they very elegantly and gently instrument the airway, and they're able to achieve endotracheal intubation. When you're beginning to learn laryngoscopy, I don't want you to do that. I want you to optimize everything as best as possible. What that means is I want you to scissor the mouth open with your thumb and finger, and just scissor it and see how much wider you can open that mouth. And really that's optimizing your ability to insert the blade and to visualize the airway. Once you have the mouth open, then gently insert the blade and simply brush the tongue aside, in a sweeping motion, and you can direct the direction of the laryngoscope blade to the corner of the room. Now, Then what you can do is gently with pressure, elevate. Do not rock back like this. That can damage the patient's teeth, as well as be careful about trapping the lip between the teeth and the blade. You don't want to explain a chipped tooth or a bloody lip to the patient when they wake up. And really, you should be using really light to moderate pressure. You should not need to use heavy pressure. If you're using heavy pressure where your hand is shaking, or if the patient's head is lifting off the table because you're just using too much pressure. And you really don't need to use that much pressure if the blade is placed properly in the airway. So once the blade is in the mouth, the next thing I want you to do as a beginning laryngoscopist is to speak out what you're seeing to your attending, because your attending can't really see what you're seeing, and you want to make sure that you're communicating at all times what you're visualizing in the airway. You can get guidance from your attending. So I'm inserted the blade, I am seeing tongue, I see epiglottis. Now I see a grade 1 view of the cords. The next thing that I just did that you shouldn't do is once you see that grade 1 view, then keep your eye on that grade 1 view or that view and don't look up, and just insert your tube through that glottic opening. Okay? Once the tube is through the glottic opening and that pilot balloon has passed the vocal cords, you can stop. A lot of times, as beginning laryngoscopists, you're so excited that you got it in that you keep pushing and pushing and pushing the endotracheal tube further and further into the airway, and you run the risk of having a main stem intubation. So once you have it in, once the cuff is past the cords, you can then stop advancing. You can remove the laryngoscope blade. This is dirty, so you should have a bin or a surface that you can place this in that won't get contaminated. You can then remove the stylet while holding pressure here. And then you can inject the cuff with 3 to 5 cc's of air. And you can also palpate this pilot balloon to confirm that you have a good seal. The next step is to attach the connector of the endotracheal tube to your anesthesia circuit, and then to auscultate. And you want to check for bilateral breath sounds. The best way to confirm bilateral breath sounds is to auscultate both sides on the lateral aspect of the chest while you provide a big breath. Now, once you confirm that there's also no air going through the stomach and that you have adequate placement, you'll get a thumbs up from your assistant, and you can go ahead and secure the airway. People will have different preferences for securing the airway. I'll show you how I like to secure it. Now, did you just see that? I had a good assistant there. And when I let go of the tube, which I shouldn't have let go of, but my assistant was watching me at all times, and he held the tube, because you're really responsible for the endotracheal tube until it is secure. So we take some pink tape, we call this pink tape. It's very sticky, and you want to really secure to the lip, and then really close to the lip you want to do a couple turns around the endotracheal tube, and then again secure it to the other cheek. And for good measure, you can put another piece of tape over that. And what I like to do is I like to put a little eye tape over the pink tape. It helps to remove the pink tape later because it just can come off in one big piece, especially if you put little tabs here to help you pick the tape up at the end. My final tip for you is to secure the pilot balloon somewhere where you can see it. Oftentimes at the end of the case, when you want to deflate the pilot balloon for extubation, sometimes you're looking for where it is, and the best thing to do is simply tape it right here to the end of the tube so you know where it is. So that, in a nutshell, is endotracheal intubation. And I know we have really gone through a lot of information today. There'll be plenty more opportunities for us to discuss airway management with you, but we hope this is a good overview for you that will help you understand the overall process of airway management in anesthesia.